Hi everyone, I'm Shreyas Gandhi. I think I've met most people, but I'm the new urologist. I started at Headwaters in July. I made this brief video. It mainly goes through some slides about a radical prostatectomy. I just wanted to clarify the perioperative care for the procedure. So I'll go over some of the salient points. Of course, this is just a brief overview. And as we get closer to the date of actually doing the procedure, we can talk in more detail about some of the logistics. But this should give everyone a pretty good idea about what I plan to do with this procedure and the care that these patients will require around their procedure. So what I plan to cover in this presentation today is what is a prostatectomy, why do we do this procedure, and why are we offering it to patients at our site, how these patients are being prepared by my office, and then once they get to the hospital, what kind of preparation do we need to do in order to get them safely into the operating room, the OR management piece, so when they're actually in the operating room, what kind of anesthetic considerations we have to take into account, what sort of procedure we're actually doing and what steps this involves. So I'll go over what the procedure is briefly. Then once we're done the procedure, PACU care, transitioning from PACU to the floor, and ultimately when they're discharged home from the hospital. So what is a prostatectomy? So there's different kinds of prostatectomies. What I am starting to do at this site will be a radical prostatectomy. So this is the surgical removal of the entire prostate, typically for prostate cancer. Now, when we take out the prostates, we also take out lymph nodes. So we sample the lymph nodes in the area. There's two different ways to do it. There's an open prostatectomy and a robotic prostatectomy. We're going to be doing the open radical prostatectomy, so it's done through a small incision we make in the midline just below the belly button down to the pubic symphysis. Now, a lot of people often will ask me, what is the difference between a prostatectomy and a TURP? So prostatectomy is typically done for prostate cancer. This is typically for prostate cancer that is localized to the prostate that's not metastasized yet. A TURP is for benign prostatic hypertrophy. So as men get older, most men develop enlargement of their prostate, which leads to lower urinary tract symptoms. So a TURP is an endoscopic procedure that we offer for men that don't have evidence of prostate cancer for benign prostatic hyperplasia. And that, again, is something that we've been doing a lot of at Headwaters already. But it's endoscopic compared to a radical prostatectomy, which is an open surgical procedure. Now, the first step in the patient's journey when they get to the hospital is going to be the pre-op assessment area. So typically, these patients have been seen in my clinic. They have a diagnosis of biopsy-proven prostate cancer. They don't need to be pre-admitted. They typically are seen in the preoperative clinic by the nurses. They're going to get some preoperative blood work. They will get typed and screened. They will come in through the same day admit pathway for these patients. In terms of the pre-op preparation, they usually will get a bowel prep, which is organized by my clinic, and that's tailored for individual patients. So some of them will get it, some won't, but again, that's something that I will take care of through my office. They will have normal preoperative antibiotics with ANSEF. Then they go to the operating room. Now, once we are actually in the operating room, what is the procedure? The procedure, as I mentioned earlier, is an open surgery. We make a lower midline incision. So if you look at the diagram here, we are typically making an incision down from below the belly button down to the level of the pubic symphysis. It's an approximately 8 to 10 centimeter incision. It's down in the midline, so in terms of pain response, patients do pretty well. Once we are inside the abdomen, we typically like to stay extraperitoneal if possible. We start with the lymph node dissection. So if you look on the diagram here, we have the right side, so which is here, and then the left side. So we do a lymph node dissection on both sides. Typically takes about 15 minutes per side. We do a right iliac artery and vein lymph node dissection. We send this off to pathology as the right pelvic lymph nodes. Then we do the same thing on the left side. Once we are done with the lymph nodes, we proceed to focus on the prostate. So we actually start dissecting the tissue around the prostate. So if you look on the diagram here, it's showing you the male reproductive system. We have the bladder, prostate, prostatic urethra. So the urethra runs through the prostate, and then it goes to the penis where it becomes a penile urethra. So when we are taking the prostate out, we take the prostate along with the prostatic urethra out en bloc. We take everything out together. On this slide, we see diagrams going from the left to the right. So as I was mentioning earlier, we take out the prostate along with the urethra. Now, once it is removed, you see that there's a gap that is present in between the bladder and the urethra, so we have to put that back together. These little yellow nerve endings we see here are nerves that are important for erections. We try to save them as best as possible, depending on how aggressive and locally invasive the cancer is. Now, if you look at the diagram on the right side, we typically put the bladder back together with the urethra using sutures. So we put 3 sutures up on the top, and then 3 sutures at the back. Everything heals over the catheter. So once we put the sutures in, the catheter is very important and it should not be removed prematurely. Once the surgery is completed, the patient will go from the operating room to the recovery room. The patient will have 2 drains. One is a Foley catheter, which will be the straight drainage. There is no CBR required for these patients. We do not need to irrigate their bladder. The second drain is a JP drain. In terms of PACU care, standard PACU care, there's no special considerations for these patients. If the Foley is blocked, it may or may not require flushing. The urine output is typically light pink. That's quite normal. We monitor their JP outputs and their urine output and their pain management as per our anesthesiology colleagues. Now moving on to the floor care. So once the patient is stable in PACU, they transition to the floor. Now in terms of their post-operative considerations, especially for nurses that are looking after these patients on the floor, medications and pain management, how do we prevent and manage complications if anything comes up. Early ambulation is key for most surgical patients, but especially these patients because they go home fairly quickly. And then catheter care. In terms of medications, some patients require antibiotics after the surgery as well. This is catered on an individual basis for prevention of infection. Because the anastomosis between the bladder and the urethra is very close to the rectum, we often do not want these patients to be constipated. So they may or may not require stool softeners and laxatives, and we try to prevent constipation as best as we can. Because they have a catheter inside their bladder, they may also have bladder spasms, so we sometimes put them on prophylactic medications such as oxybutynin or another anticholinergic to prevent bladder spasms. This may also be mirabegron or another medication, but if the patient is having a lot of spasms, you let the primary surgeon know, and we can put them on medications to help prevent these spasms. Pain management wise, some patients may or may not have a PCA. Typically, as I mentioned earlier, the lower midline incisions are not very tender and patients tolerate them pretty well. So usually Tylenol dilaudid is enough for pain control. They get the usual antiemetic medications, and they are on prophylactic adult parent starting post-operative day 1. Continuing on for post-op care, we will monitor their ins and outs. So keep an eye on their JP outputs, keep an eye on their Foley output. The JP usually comes out before they are discharged. They're typically discharged 1 to 3 days after surgery. It's very important to be careful with their catheter. As mentioned earlier, the anastomosis, the connection between the bladder and the urethra, heals over the catheter. So do not remove the catheter without letting me or the primary surgeon know first. The catheter can be flushed, that's not a problem, but we should not be removing it before consulting the primary surgeon first. They usually go home with the catheter. We encourage lots of fluid intake for the first 24 hours. They're going to be on IV fluids and then transition them to PO fluids. In terms of diet, they're typically going to be clear fluids that evening, the first evening, and then diet as tolerated with solid foods the next day. We observe the catheter, make sure it's draining. If it's blocked, we flush it, evaluate the color and the consistency of the urine, do the routine dressing checks. They're typically going to have staples for their incision. The JP drain, as I mentioned, will come out prior to discharge. We typically like to avoid any rectal temperatures. We don't do a lot of that anyways, but because the rectum is close to the anastomosis site, we want to avoid doing any rectal temperatures. And as I said, typically home in 1 to 3 days' time. In terms of discharge instructions, I'm going to be very hands-on for the first 3 cases for sure, but generally they all go home with a Foley catheter. They will typically follow up in my clinic 10 to 14 days after the procedure for Foley removal. They will go home with pain medications, stool softeners, and some medications for bladder spasms as needed, and the typical recovery instructions after any open procedure, such as avoiding heavy lifting, avoiding baths. But again, I'm going to make a handout for this patient, so they're going to have a handout to go home with, and I will be counseling them on an individual basis. So that, in a nutshell, is my plan for these radical prostatectomies. As we get closer to the date of the surgery, if anyone has any questions, feel free to reach out. I'm always available by phone. Of course, for the first 3 cases, I'm going to be hands-on as well. So we'll be very involved with the care of these patients. Thank you. Please let me know if there are any questions.